This is always a joy to talk about, first of all, dementia, because it's very close to my heart in terms of taking care of dementia patients. But I'm a geriatrician, so I take care of older adults. And if you want to consider what my specialties are, it's in long-term care, dementia, and end-of-life or hospice and palliative care. The buck stops with me, I always say, is unfortunately my patients die. My goal is the best quality of life, all right, for the duration of their life, and the best quality of care. So I also run a geriatric fellowship program training young physicians to become geriatric physicians. For all of you in here, and my advice, and certainly when I'm in the training process, I'm training them so that they know me and how to take care of me when I get older, because I'm kind of picky. But also I would recommend that geriatric medicine is a lot different than primary care medicine. That's internal medicine or family medicine. The whole principles are quite different. And actually, if you look back at what's happening in our primary care medicine, you see the changes that might be occurring, more of a holistic approach, more of a team approach, more of a shared decision making, and also planning for advanced directives in terms of advanced care planning, so to speak. What happens if I get this, or that as I get older? Dealing with dementia, the primary emphasis on this particular talk is what can we do with regards to patients who have behavioral issues with dementia patients, and is marijuana possibly a role in terms of how we might look at alternative ways how we manage these behaviors. In addition, there's a lot of confusion there's a lot of confusion as far as what the hell is marijuana? And I would guarantee you that if I go around, I bet you I might get 10 or 15 different answers of what marijuana is. And then if I bring up the term cannabis, what's cannabis? Okay? So I hate to say this, but much like I had to do is I have to learn some basics, so I'm going to go over some basics. So that when you see something advertised like CBD oil is being advertised on every street corner that you can buy it here, what is it that I'm getting? Because then what's the difference between marijuana and CBD oil? Or is there a difference? I don't know. So I'm going to go into some basics, and then I'm going to talk to you about some of the studies with regards to the use of marijuana, where we stand with regards to the use of that, some of the positive pros and cons, if you will, of it, and then switch into where do we stand with regards to the use in dementia or Alzheimer's dementia. Before I start, I want to ask, how many of you are caregivers or have experience with patients who have dementia? Good. A good portion. So you'll be definitely interested in where we stand with regards to the use of cannabis, if you will, in our patients who have dementia. The first slide up here is I have geriatrics and polypharmacy. Good and bad news is we're living longer. The bad news is that we have more medical problems as we grow older, and therefore usually that means that we're on a lot of medicines. So, and docs, particularly our specialists, like to prescribe a lot of medicines because they say you can't live without them. I'm on the other side, and the other side of that is that I'm looking at people who are on these drugs but are having adverse effects of those meds. And you know what? A lot of the drugs that we use have what they call black box warnings. That means that you could die from them. So it's a constant balance, if you will, in terms of always assessing the benefit versus the risk. Overall, and all of us as healthcare providers, is do no harm. All right? That's easier said than done, okay? And you'll see why maybe as we go on. So let's take a look. The next slide is the problem. Behaviors are very common, the most consistent abnormality that you're going to see over the course of dementia. The course of dementia varies anywhere, Alzheimer's dementia, between 8 to 10 years, but it goes anywhere from 3 years to 20 years, all right? So you can see the differences in terms of lifespan. And now there are multiple types of dementia. As anything in this world, it gets more complicated. So we're finding different forms, and each of these different forms have a different we'll say memory effects, if you will, and other neurological deficits that we really have to be astute enough to pick them up, because it really does mean, is this particular type more prone to behaviors versus not? And if so, how do we differentiate that, and how are we going to adjust our medications, okay? And the behaviors are characterized, for any of you that are involved in taking care of some dementia patients: agitation, verbal and aggressive behaviors, all right? And what does that mean? Hitting. Patients are hitting, slapping, biting, kicking. Anybody have experience with their patients on that? Okay. That's disturbing, all right? Or the good old yelling and screaming, help me, help me, help me, help me. Shut up, will you? All right, and you just want to say that. But these are all problems and they're difficult to manage. And by the way, how we manage them is different. Starting off by, I want to say that the significant thing is that there are serious complications that can be associated with that. I can walk up to you and I could say, you know, you're a son of a bitch, all right? And you're going to slap me, all right? How dare you say that to me? So number one, patient may get hurt. The other resident may get hurt. And if somebody's trying to do activities of daily living, cleaning them, changing them, whatever it is, they may get agitated. They may kick and scratch. Is this common? Yes, it's very common, okay? And the question comes up is, well, what do you do about it, okay? And the problem is that the treatment options are very limited. I can go through a list of about 4 different medication groups, and we've tried them all. And each of them are associated with complications, all right? Some more serious than not. Some of them, as I said, that can even result in death. The more common drugs that have been used, all right, now have the black box warning saying that you could die from this from sudden cardiac death. That's only a minor, not a minor complication, but that's only one of the many complications that are associated with taking these medicines. Next slide, please. So, possible solution. Can the use of cannabis be of benefit to assist in the management of these behaviors? Next slide. So, first thing is, what is cannabis and what is marijuana? So I'm going to go through some basics, and just so we all understand that and hopefully bring it home in terms of what we're looking at when we're trying to evaluate the benefit versus the risk of using marijuana or cannabis, all right, in our patients. So next slide. So the cannabis plants, which are oftentimes said the marijuana plant, so they use them interchangeably, but it really is a cannabis plant, all right? And originally they were from East Asia, but now, as we all know, they're cultivated throughout the whole world. So everybody's growing marijuana, all right? Original use was industrial fiber, seed oil, hemp seed oil, for example, hemp seeds, for recreational purposes, religious and spiritual purposes, to elevate the mood, and lastly now, more recently, with the medication that we're looking at in terms of, is this an appropriate type of medicine? You actually have 3 different strains. The most common ones, there's probably several ones. The sativa, the indica strain, and one that we don't hear much about is this 3rd strain, which is ruderalis. And the sativa, notoriously that strain, so if you have a plant that's high or of the sativa strain, it's where really most of the marijuana, in quote, marijuana as we say it, which is invigorating, uplifting, okay, activating, if you will, makes you feel good, as opposed to the indica strain, which is more sedating, relaxing, makes you sleep better, okay? There's a characteristic of where CBD comes from, okay? So the next slide. So the 2 main varieties that we see coming from these plants, and I'll start by saying there's a term that they use is phytocannabinoids, all right? And we'll just use cannabinoids in general. It's a technical term, I realize that. But the reason I'm using that is phyto means that they're the naturally occurring, which is where marijuana comes from, literally. And then the endocannabinoids. And guess what? They're in our brain. We have marijuana going in our brain. Let's call it cannabis as opposed to marijuana. All right? So it's kind of tricky. We'll get to that a little bit more. So marijuana has a high THC content, psychoactive, intoxicating. This is what we traditionally see on the streets, and everybody's taking it, particularly for all those medical problems. It's interesting how the young people have more medical problems than the older people when it comes to use of marijuana. It's kind of interesting. All right, and then hemp. all right, which is basically CBD content in what we're seeing, the CBD oils and different products from CBD that we're seeing on the market, all right? It's not psychoactive, it's not intoxicating, and again, this is where most of the uses was for industrial use. Again, hemp seed, hemp oil. Now, the amazing thing is that this last thing, these are chemicals that circulate, or that are found in this plant. There are approximately 480 different chemicals that are in a marijuana plant. Okay? And second of all, of those known, there's about 65 that have some chemical structure that are related to the endocannabinoids, which are the ones that are circulating in our brain. Okay? So it's a plant, and you say, well, you know, where should we really be dealing with this? But how many of you are familiar? Everybody's familiar with penicillin. Where did it come from? It comes from a mold. Okay? So it'd be surprising how many things we might get out of natural products that may be of benefit to us that we don't know about. The problem is we need to study it and decide what is appropriate, what isn't appropriate. So some of the terms that you may hear. Marijuana, the main ingredient in that is THC, and that mostly comes from the flowers, all right, and the leaves of the plant. When you get down to the stalks of the plants, this is where hemp is derived from the stems and the stalks. Then you have terpenes and terpenoids. That sounds interesting, isn't it? But how many heard of aromatherapy? All right? So everybody's heard of aromatherapy. That's basically terpenoids. It's a class of chemicals that gives a scent. All right? I was recently in Amsterdam, and it's like on every other corner is either a coffee shop, which is literally a marijuana shop, as opposed to a cafe, which is a coffee shop, or a head shop, all right, which is all marijuana. And it was kind of interesting because I went in there and they say, well, this is a lemon flavor, this is a strawberry flavor, this is a caramel flavor. I mean, how many flavors do you have? But nonetheless, this is basically what they're talking about. The terpenoids end up making the smell. That they have various medicinal effects, such as lavender, for example, is relaxing, it helps you go to sleep. So theoretically, the terpenoids have some contribution to the effects of marijuana. And then you have hash and hashish, all right, which is basically an extracted cannabis product composed of compressed, purified preparations of stalk resin gland, and hashish is oftentimes the drug that they refer to, which is the resin of the cannabis plant. This is something that normally is smoked a lot. So for some of the younger people, this is probably old hat in here. Am I right? I'm looking around for the younger. Nobody's even acknowledging that. All right. And then lastly, and this is where you got to keep in mind, for those that are growing marijuana plants, if you take a marijuana plant and you just crush it up, put everything in it, that's what you're going to get. And you're going to smoke it, but you don't know what's in it. And that's a real problem in a sense. You don't know if it's got a lot of THC. You don't know if it's got byproducts that are dangerous for you. So, and that's why buying street marijuana is really raises a concern in terms of what you're getting in that product, okay? So it's very variable therapeutic effect. I don't know if you know, but recent statistics since marijuana has been legalized, the number of ER visits associated with acute psychotic reactions related to that have gone up significantly. Okay? So the only point is to point out some of the concerns that you have with what you're getting and what effect it's going to have on you, and the concerns that we all have. And so if I, as a geriatric doc, is going to be prescribing a medicine for you or your loved one, my concern is, am I doing more harm? Am I going to create some problems, okay? So, as I mentioned, hemp is predominantly CBD. This is normally what we're getting when we go and get some CBD. All right, it has a lower concentration of THC. It is the only legalized form of cannabis that can be prescribed without a prescription. You know, in order to get marijuana, you have to have a marijuana card. In order to get CBD, you really don't. Now, the good news is that it recently has been reclassified. I think it's reclassified in 30 states. Arizona is one of them. So let me go back and just talk about, when I talk about a Schedule 1, Schedule 2. Schedule 1 is no currently accepted medical use and the highest potential for abuse. Where do the opiates come? They come in Schedule 2. Proven medical benefit, all right, but a high risk for abuse, and that's why we have the opioid crisis. Schedule 5 is medications with a low quantities of narcotics and low potential for abuse. Now, I put Robitussin. Does everybody know Robitussin DM? Has everybody taken it? You know that's a drug. It has central nervous side effects, all right, theoretically. And the doses that we get or give, you're probably not going to get much. But actually, so CBD has gone from a Scheduled 1 all the way down to a Schedule 5. That's good news, okay? However, the criteria, it must be approved by the Food and Drug Administration. It can't have a content higher than 0.3, and that's varied from state to state. Some people will say 0.1%, all right? Marijuana, still scheduled, Scheduled 1 drug, so it's still not legal. Can be purchased without obtaining a marijuana card. And the federal law, keep in mind, here's the difference. A federal law, it's still illegal. CBD is still illegal. Some of you may have seen the news where the lady was arrested getting on an airplane. She had CBD cream or oil or ointment of some sort, and she was arrested. It's under, the airports are under federal jurisdiction, therefore it's theoretically illegal. And I want to mention that because from the standpoint of myself in treating this, I have to be careful. I mean, if I do it in a federally regulated facility, am I breaking the law? And the question comes, and I don't want to get arrested, not yet. I mean, you know, just go back one more, just real quick, Gene. I wanted to say, so you really have to be careful. Federal law still has its CBD oil, and other cannabidiols are listed as Schedule A. And the newest drug, which is mostly CBD, is Epiliodex. I don't know if you've heard about this, but this is the medicine that now has been approved for seizures in young kids. And it's really thought to be a benefit. The studies look promising. And there's a couple of new drugs that are coming out soon, and I'll allude to them as we go on. Next slide, please. So these are the benefits, all right, potential benefits, all right? Keep in mind that CBD is non-psychoactive, and there are very few side effects. We've already talked about the pediatric seizures. Epidiolex is one. Anxiety, nausea, vomiting, inflammatory conditions, pain, Alzheimer's, dementia, Parkinson's disease. Been actually studied more in Parkinson's disease than in Alzheimer's dementia, all right? But so these are some of the potential benefits, and now if these are benefits, why aren't we looking at them more closely and try to determine, you know, what are these benefits and are there any potential side effects? Next slide. On the other hand, THC, I'll talk a little bit more about the ratios. THC is activating, and CBD counteracts that activation by causing relaxing. So if you combine the two, it is thought that you may potentiate the effect of the eventual effect of any of the symptoms that you are treating. On the other hand, the CBD counteracts. You just don't want to give the THC to, you know, having everybody sort of activated, if you will. That's what you're trying to suppress, particularly in patients who have a cognitive impairment. All right? But pain is probably the biggest area where we're talking about. And this is arthritic pain as well as what they call neuropathic pain or peripheral neuropathies. Opioid modulation, we're going to get to that in a little bit more, and I'm going to tell you a little bit about how I think that there is some positive things coming out of the use of the marijuana that we're seeing. In dealing with anxiety, insomnia, and spasticity, the spasticity associated with multiple sclerosis. So there is a new drug that's going to be coming out soon, if any day, is going to be approved for the use in patients who have multiple sclerosis, and has an appetite stimulant. And I'm a little bit more or less disappointed in the one that we currently have. We have a drug called Marinol, and I think it's very expensive. I've used it. I think it's a worthless drug, and unfortunately, people still ask if we can take it, and I usually say no because it is expensive, and Medicare does not pay for it. Next slide. So these are the synthetic cannabinoids, which are Marinol is the drug that I talked about with regards to appetite stimulant. Epidiolex, which is for the pediatric seizures. Saltivix is the one that's now going to be produced. It's almost there for spasticity with multiple sclerosis. Very positive outcome, but good studies, all right, that have shown the benefit, and that's what really we need. And then you have the naturally occurring cannabinoids, which are marijuana and the derivatives, and then now over-the-counter CBD. As I mentioned, you don't need any prescription, you don't need anything. You can walk in and you can get CBD, buy it. Bottom line, it's pretty expensive, so bear with me. So again, we're using CBD. Is it a benefit? And I'll give you my own personal experience as a physician prescribing it for some of my patients. Next slide. As you might guess, we all know that smoking and vaping are big things. I do want to tell you that I did bring along some brownies for you when you leave. So I hope you enjoy the rest of your day and just enjoy it. All right, these are very common. My wife just got some, but I see quite a few people in terms of using this and rubbing it on arthritic joints. I'm going to say it's probably 50-50, and keep in mind you always have to think in terms of placebo. Something soft on your arthritic pain might make you feel better, but it isn't really truly doing anything for the inflammation. Then the tinctures and oils, this is what we are more or less using in our studies because it's easy for the patients to take. The problem with the edibles, it's highly variable of how much marijuana, if you will, is in that particular cookie that you're taking. And now you know in alcoholic beverages as well as soft drinks, they are now putting CBD in those drinks. And lastly, transdermal patches and suppositories. Hopefully we don't have to get to that point to use those. Next slide. So what is the relationship between plant cannabis, all right, the phytocannabinoids, all right, and the endocannabinoids, yeah. All right, next slide. All right. So there is an endocannabinoid system in our brain, and it consists of, it's a biological system. It's composed of a lot of cannabinoids that are moving around in the brain, okay? All right, and they actually ask as neurotransmitters. I like this short order neurotransmitters. Basically what I'm saying is, say if you feel depressed, okay? The cannabinoids will have an increased secretion of those. They'll hook onto the cannabinoid receptors and maybe counteract the depression. Does that make sense to you? You follow me? So it's a chemical that attaches on, or the chemical itself that's going to cause a reaction. That's the same mechanism as all the other drugs that we use, by the way. All right? How many of you heard of serotonin? Okay. So serotonin, same thing. Okay? Basically the same thing. And look how much we've studied with serotonin. All right? Dopamine, another one. These are all chemicals that circulate in the brain and are neurotransmitters that create some kind of a reaction when they hook onto a receptor, okay? So the two that we know of now, and there are many, all right, is what 2-AG, and you don't have to know this, but these are mostly found in the brain. And then anandamide is the other one, which is found in higher concentrations of the body. Now, the reason I say that is that they're all over the place. So you have certain ones that are predominantly in the brain and certain ones that are predominantly in the bloodstream circulating in the body, okay? Now, they're also broken down. And maybe this is a little too technical, but CBD and THC work a little bit differently. CBD attacks this enzyme which breaks down cannabinoids, okay? And you don't want to do that. I'm going to just say if you use Parkinson's disease, you have dopamine and you have an absence of dopamine that gives you the Parkinson's symptoms. So the question comes up is you don't want to take something that might be a benefit for you and decrease that, okay? On the other hand, THC acts directly on the receptors, all right? And if it gives you more of a prolonged effect, all right, for whatever that endpoint is on the receptor, depends on what system it's in. If it's in the system of the hypothalamus, for example, it may improve your appetite, okay? If it's in another system, it may help your memory, if you will, all right? So there's different mechanisms. We just don't know enough about them yet. Next slide. Then these are the receptors. CB1 receptors, which are found mostly in the brain and spinal cord. And then these, they're concentrated in the brain regions associated with that behavior. So again, I mentioned the hypothalamus, and maybe it's going to stimulate the appetite, for example, and just using that. Again, cannabinoids, you give them and they're going to stimulate the appetite. You hear the rationale behind, the thinking behind, is there a benefit for appetite stimulant, okay? And then the CB2 receptors found in the peripheral nervous system. Now this is where the anti-inflammatory approach comes in. So it works on the immune system and it creates an anti-inflammatory. So if you have arthritis, theoretically, all right, it's going to make the arthritis feel less inflamed, if you will, as an anti-inflammatory drug. And I don't know if as we get older, the non-steroidal anti-inflammatory drugs, these are the Advils, the Naprosyn, and a whole host of medicines that we take for our arthritis. But as we get older, there are more complications associated with it. So for all practical purposes, they almost become contraindicated in our older patients. Again, what alternatives do we have for managing pain? Okay? And I won't go into that. Next slide. So let's take a look. These are the things that internally in our own brain that they may be affecting. Appetite, metabolism, pain, sleep, mood, movement. It goes all the way down. All right. Now the reason I say that, our older patients, but better yet, dementia patients, have trouble with the appetite. They may not eat. They have pain that they can't describe, so we don't know whether they have or have not pain. But the older you get, more likely you're going to have arthritic pain. Sleep, insomnia is a common problem. People have sleep disorders. All right, and mood, so it waxes and wanes. Sometimes they're more activated, other times they're more sleepy, so we really have to deal with that. Remember, they also are involved in our basic functions, our everyday living. Okay, next slide. So, the latest term that's coming out is, are there individuals which have a lower amount than are necessary to maintain good health, vitality, and well-being? All right, so this is called an cannabinoid deficiency, and is there a syndrome that occurs? Now let me give you just a rough, maybe guesstimate, because it is being used. How many people are familiar with fibromyalgia? Okay, everybody, okay, good. All right, it's sort of a depressed affect, aches all over, okay? Do you think maybe it could be that there's a cannabinoid which affects all of these areas that our patients complain of with fibromyalgia? It's being tried. So far, there are no definitive results, but I notice that they are using it more and more in people who have fibromyalgia with the hopes that, because there is no good treatment so far, all right? And there's a lot of treatment that's out there. Question is, note, I said good treatment. So it's always possible to look into this. So it raises the question is, why are we looking at this? If we look at dopamine deficiency, serotonin deficiency, why aren't we looking at the cannabinoid deficiency that occurs in the brain? Next slide. So, and why is there more need? This is certainly the reason why there's a need for more studies. Next slide. Okay, I'll start off by saying, is there a plus side, all right, to the use of marijuana that's been described? We talk about all the symptoms that are associated with it. Okay, I feel high, that might be considered good. A lot of these others we're not sure of, but we still use it with the hopes that we're going to feel better, have a good time. Sometimes it's the difference between taking an alcoholic beverage as well as a puff of marijuana. The trade-off is you're going to feel better, maybe with both. Which one has the least amount of side effects? There are those that would argue marijuana has the least amount of side effects. I'm not going to go there. But let's go. Studies have shown that there is a reduction in prescription medicine. So let's take a look at that. A very important slide. Next slide. So changes associated with state having a medical marijuana law in numbers of Medicaid prescriptions for drugs used to treat conditions with medical marijuana. Look at this. Anxiety, depression, glaucoma, nausea, pain, psychosis, seizures, sleep. The only one is spasticity. Not quite sure why that fell out, to be quite frank with you. But the bottom line is, so there are some studies that you can look at CMS, the Medicare, Medicaid data, and come up with, there's a reduction in the use of medications for each of these. Next one. even more important, okay, in consideration of the opioid epidemic, all right, we have now, look at over here, this is an average number of daily doses filled with a prescription drugs annually per physician in states with a medical marijuana law by condition category study compared to the average number in states without a law. Look at the difference, and the one I point to is pain, okay? Now, we're in an opioid crisis. Now, I don't want to say that we're going to trade an opioid crisis for a marijuana crisis, all right? But the point being is that we really need to look at this very, very closely because we are in an opioid crisis. And the question is, do we have an alternative, all right, in terms of particularly going through withdrawal and some of the other medicines that we give to our patients who are addicted to opioids. So that's a very important statistic, I thought, and perhaps a benefit that we need to look into a little bit more. Now, as you know, there's also on the other side, in states who have legalized marijuana, there's an increased incidence of motor vehicle accidents. All right, so a lot of negative things that obviously is quoted in the newspapers, and you can quote it either way for those pro, those anti-marijuana use. My concern is that we just need more studies in order to make sure that we know what we're doing. Next study, next slide. So this gives you an idea of the different studies. If you take a look at the number of studies, all right, these are controlled studies. 28 for pain, 28 for nausea, vomiting, 14 for multiple sclerosis. And if you take a look at the patients, now the point is, in order to have an adequate research study, you really have to have large numbers. And what's problem is that if you go all the way down and looking here, sleep disorder, psychosis, anxiety disorders, all right, there are very few studies. You're really looking at them here. And this is from 2015. Now, this was a meta-analysis, so basically the Cochrane study, what they usually do is they look at all these studies that are put together, all right, that have been done on marijuana, and they try to analyze whether they've been good studies or bad studies. In this case, they just look to see if there were studies. But take a look at these numbers. I mean, for 24, glaucoma is something that wherever it is, there's only a few, six studies for glaucoma, and yet that's being billed as something that you can use marijuana for glaucoma. And for sleep disorders, all right, which are very common not only in our patients with dementia, but in our older population in general. So you could see there aren't many studies. Next slide. So, pain management, since that is it. So again, here was again another Cochrane study where they looked at all these different studies. Now note, a lot of these with cannabinoid, with THC, and the others are usually with pharmaceutical companies. But if you really take a look, all those dots or squares that are on the right side, all right, show that favors the use of marijuana. All right, those on the opposite side, no and negative. I didn't go into each of these studies to see whether they were good studies, bad studies, whatever they may be. I'm going to point out some problems that we have with our dementia patients in terms of doing studies and how effective they are, and the problems we have on judging whether or not they are really truly an improvement or not. And I'll go into that a little bit later. But the consensus is that they probably do help in pain. So let's take a look at that, and can we find something the pharmaceutical industry is trying to produce, an FDA-approved drug, all right, which will have the combination of THC and CBD, and to try to see whether or not it's effective or not, and hopefully, like some of the other drugs, we'll get that passed so that you are able to take that, whether it's federally regulated or not, that you will be able to take that as a drug. Next slide. Don't go too far with this, but I will tell you this, all right? And much as I talked about serotonin and dopamine, all right, there is some consider in some of the basic sciences that maybe marijuana is neuroprotective. Now, one of the things is with regards to marijuana, they say it creates apathy, all right, over a long-term use, chronic use, but we don't know what that chronic use is. So the question is a little bit okay, or is too much not okay? So we don't know the answer to that. So the bottom line is that, it may be neuroprotective. Now, again, I don't want to go into this, but I will slow it. But much as I talked about serotonin, dopamine, and cannabinoids, all right, with dementia, acetylcholine goes down, all right, and the drugs that we have available increase the acetylcholine, all right, and that improves memory. That's just a very simple, simplistic version of what happens in Alzheimer's dementia. But THC competitively inhibits cholinesterase inhibitor, all right, that's what breaks down acetylcholine. So, and that's how the mechanism of these new drugs work, is they destroy the enzyme that destroys acetylcholine. Are you all following me on that? I mean, is that okay? You got it? Okay? So I'm trying to, so that is one mechanism. The other is there's still a theory that, that this is an anti-inflammatory process. So we're looking at drugs perhaps that would be anti-inflammatory in nature. One of the drugs that promoted that maybe you don't even know about is the statins are anti-inflammatory, and a lot of the benefits of the statins are from its anti-inflammatory effects. So the question comes up is, this is somewhat like an antioxidant, and actually there's some pretty good studies with our diet that we take, which is high in antioxidants. Is a good diet is one of the factors that you can be on to delay the onset and progression of Alzheimer's dementia. So, I mean, we can do a lot of this on our own. The question comes up is there an effect on, from the, we'll call them cannabinoids for right now, in terms of perhaps delaying the onset or improving dementia in our patients? This we don't know. I'm not looking into that now, but there are some studies. Next slide. So these are the drugs now in dementia studies that have been, and I'm going to kind of go over these a little bit quickly, but Marinol is the only drug that has been approved for appetite stimulant. That's predominantly its effect. We've used that, and it supposedly causes decreased agitation. I'm just going to tell you right now, I think it's worthless. I think it's an expensive drug that has very little effect, and I don't prescribe it because it's not covered by Medicare, first of all. You have to pay for it, and I just don't think it's of any benefit. So most of the studies that came out are really using low dose. Everybody's concerned with THC, and for justifiable reasons. It makes you high. So if I have an agitated patient with dementia, do I want to give them a drug that's going to make them more agitated, okay? So what they did is they gave a low dose of THC, all right, and it didn't appear more beneficial than placebos. In a small study, only 58 patients received this, and they received a relatively small dose of THC over a period of time. Did not have CBD in it. So the question comes up, or it may have had a little, but mostly it was a THC study. So then they went to a little bit higher doses using cannabis oil, and in 11 patients. Now, I want to tell you again, 11 patients means nothing. How many of people have heard of Prevacin? Yeah, Havison. I know, even if you're taking it, I'm going to tell you it's a waste of money. But, all right, the point being is that the studies that were done are absolutely ridiculous. And how they have marketed that, I think, is really pathetic, because they are making tons and tons of medicine on this drug. It's not a drug. You can get it over the counter, but I think it's cost you like $60 a month, something like that. And I just think it's a shame. We're a vulnerable society, and we don't want to get dementia. So if somebody advertises this drug, no harm, but you're paying $60 a month. If you're on a limited income, that's a lot of money, okay? Plain and simply. But these were done on hospitalized patients. Now, the NPI is one of the tests that is good for monitoring behaviors in dementia patients and in non-dementia patients, period, okay? But mostly in dementia patients. Now, these were patients who were hospitalized. So let me just say, when a hospitalized patient with dementia is hospitalized, there are 18 other different things that can be going on, the most common which is delirium. So we don't know if it helped the delirium or the dementia. They seem to say that it was improved, and maybe it's a drug that we should look at as opposed to some of the more toxic drugs that we use in hospitalized patients who develop delirium. Maybe we should look into them. The Cochrane review, all right, basically found no evidence that cannabinoids are effective in reducing symptoms. So that basically saying is all the studies, it's inconclusive that there is any benefit. That doesn't mean that they're abnormal. Next slide. I like this study that recently came out. It's a study from Sweden, and it came out in this past, in April of 2019. And they did, and the reason I like this study is because this is along the studies that we're doing in our dementia units, okay? They were in a dementia-directed care facilities, and Jan mentioned to you that I work out of a facility called Silverado, and it's a dementia-directed care assisted living facility, all patients with dementia. It's a prospective study, so we're kind of starting with a baseline, all right? But anyway, they did 10 female patients. I have no idea why they only included female patients as opposed to male patients with severe behavioral problems. And they were given larger than previous doses of cannabis. And here's this ratio of CBD and THC. So if you're going to give larger doses of THC, you want to counterbalance that with CBD. Now the question comes up is, are we negating the effects of THC by giving the CBD or what? Nobody knows this answer, okay? We don't know this answer, but they did monitor the behaviors, and the results shows a 40% improvement in behavior scales, and they used a decrease of psychotropic medicines. Now I will tell you here, if I have somebody on psychotropic medicines, all right, and then I decrease their medicine, you know, they're more alert, more active. And so what are we dealing with? We're dealing with the excess disability associated with these medicines. So the idea is, was it the marijuana or was it us just decreasing the medication, okay? Improving of daily care and improvement in direct contact. So if you're a zombie on much medicine and I take you off the medicine and all of a sudden you're communicating to me. I'm just saying this is some of the difficulties that we have in studying this. It's just not an easy thing to study. However, the relief, there was no adverse side effects, which is great, and there was relief, was persistent after 2 months off the medicines. And by the way, when we take patients off medicines, oftentimes they get better and stay better, with or without marijuana. So it is tricky. Next slide. This is the Arizona study that we're talking about. And first of all, I want to talk about some of the problems we have encountered with regards to beginning this study and doing this study. We're in the process of it now. But you have to get a marijuana card. And from Arizona, the state of Arizona, the question comes up is if you have a patient who has dementia no longer capable of making their own health care decisions, then does the caregiver be responsible for getting a card? But basically now the consensus is that both the caregiver as well as the patient have to get a card. Now this entails, now take a 90-year-old with dementia who has had dementia for 8 years. Do you think they have a driver's license? Do you think they have a recent photo? Huh?
You hope not.
Yeah, you hope not, is right. So my point being is it's really hard to get this information, and it becomes costly. I don't know if any of you know what the cost of staying in a dementia-directed care facility. I mean, it's anywhere from $5,000 to $8,000 and continually going up, okay? That's a lot of expenses. Now you throw another expense on. We need the cards. We're going to get the medicine for free. So you need the necessary information, and the left doesn't know the right, to be quite frank with you, as far as what the actual law is. So, and there's still a lot of confusion, and I hear different things. And the other concern is liability issues, all right? The facility maybe not wanting to take an effect of side effects. Now, I want to consider this as a pilot study and not what they call an institutional review board study, which is much more scientific. But I want to get some preliminary data and then go and get a randomized controlled study that would allow me to have more teeth in this. So we're at this point, we're using anywhere from 15 to 20 patients. And keep in mind, I don't know that I could get this done in a federal facility, so a skilled nursing facility that's under the regulations of federal regulations. I'm not quite sure I can do that. And as I mentioned, the liability concerns. At this point, though, I'm at least glad that they have legalized marijuana, medicinal marijuana in Arizona, that allows me at least to open the door and start these studies. Yes?
Do you have to go to your PCP to get a prescription for a marijuana card?
Well, you have to go through a Medicare, or I'm sorry, a marijuana prescriber usually. All right, so I'm a marijuana prescriber, and so it's okay to order it. I put my name, I fill out a form, but your PCP can do that also. It's very easy to get a marijuana card rather. So, but for this, in this particular study, I'm the primary care physician for the most part, and if I'm not, I will get it through the primary care physician of whoever's the physician for the Alzheimer's patient that's not a patient of mine. Next slide. All right, so this is our study. Anywhere from 10 to 15 to 20. We have approximately 15 patients that are signed up, about a 16-week trial. We're using the cannabis oil that's been shown to be the best route for patients who have dementia with a 2-to-1 CBD to THC. All right, now the other thing I wanted to mention is if you're going to get THC, it has to be quantified. All right, because if I get THC from you and you and you from a particular company, it's liable to be a different amount. I don't know the amount, okay? And that's one of the problems, particularly when you buy stuff in the street or on the market, wherever you're going, you don't know how much you're getting. And that's a real problem, okay? And we're going to gradually increase these doses every 2 to 4 weeks and see what kind of a response we are. We're going to follow, all right, with a washout period of time, much like the previous study, and see whether or not we've done some benefit with this. But again, all those things that we talked about is, where I want to get is the initial, start this on initial patients with behaviors before they are on the more serious and more toxic drugs. All right, we haven't got that far yet, but hopefully that would be the initial drug that we might try, and I'd like to try that rather than seeing patients on multiple medications. All right, so we're going to use the appropriate scales. We're going to have nursing observation, which sometimes can be really subjective as opposed to objective. Looking at drug reduction, including the use of breakthrough medications, obviously looking for the adverse reactions and making sure that is there some reversion back to the original behaviors after we stop the marijuana. Okay, next slide.
What is breakthrough medication?
Breakthrough medicine is, I order as needed medicine, so if you really get agitated while I'm getting your behaviors under control, I'll have them give you some medicine to calm you down during that period of time while I'm working on a broader perspective of getting your behaviors under control. Our philosophy is always start low. So rather than starting high and knocking the patient out, I would rather start slow and go slowly, but occasionally a little bit may not be enough, and you may need some breakthrough medicine. Okay? Okay, everyone? So the side effects, perhaps one of the more common ones is increased anxiety associated with tachycardia, and that's the THC. That's what you get when you take marijuana, okay? You get a little bit more anxious, all right, some people. All right, that's one of the side effects of too much THC. Elevation of the blood pressure, tachycardia, decreased concentration, sleepiness. So then you get the CBD that might be kicking in, headaches, dizziness, paranoia, and hallucinations. I mean, most of our patients who have dementia and behaviors have hallucinations or paranoia. And they have delusions. And so we don't want to make those worse. And the number one factor that we have to look at for this is the drug-drug interaction. Okay, I've had negative success, not good success. In fact, I think I've made situations worse by combining marijuana with antipsychotic drugs. That bothers me. It makes me very hesitant. First slide, do no harm. All right, so am I doing more harm or less harm? And I hate to say this, I don't know what the hell I'm doing with the marijuana. I mean, I really don't, because we don't have any studies. So, but this is the biggest concern. I go back to the dopamine, serotonin, and now the cannabinoids in the brain, and we're messing with chemicals in the brain. So do we know what we're doing, and where are we going with that? So that's my biggest concern offhand. Next slide. So where do we stand at this particular, I guess I've not had positive experiences using marijuana. There are those that have had positive experiences. Now, the other effect is it a placebo effect, too? So I'm taking medicine, but patients don't know. So you want to anticipate that you take that placebo component. Placebo is where you give them something that's not really a medicine, and a lot of our drugs that are tested are placebo and the drug. You'd be surprised how many people respond to the placebo. A good 20–30% respond to placebo, and some studies much higher, by the way, and particularly the drugs that we use are antipsychotic drugs, by the way, that we use. We need better clarification of the current regulations regarding the use of marijuana, and then we need more liberalization of the laws aligned for more research. We've tried for years to do research projects with marijuana, but you have to go, they need to be federally approved, and it's illegal. So you can't get a study with marijuana because it's federally against the law. And this needs to be changed. I mean, you can prevent whatever you want to do, but let studies be done so we have a better idea of what's going on. So we have a lot of potential, but we're not there yet. Next slide. So our goal is provide the best quality of life. Our patients comes in all walks of life and all degrees of chronic disease, all right? And so we always need to be looking for ways that we can improve on the health. And again, here's a case of providing a best quality of life as opposed to giving medicines that are going to give you a poor quality of life. It's a balancing act. It's difficult. There is no magic answer, all right? But this is what ultimately we're looking at. And so the next slide. So be careful what we wish. Everybody in this room that came to this lecture, I'm sure, is saying, I hope marijuana is perhaps an answer that we can use in conjunction with making our patients feel a little bit better, okay? Number one on the list, by the way, it's an industry, all right? And they are expanding in leaps and bounds. And what do you think? There's much money being invested and made in its success, all right? We are a vulnerable population, okay, and looking for instant relief. We always have been, will always be, and I don't blame us, but at the same time, we can be exploited, and I think I'm throwing the words of caution out. And we're not sure yet of the short and long term. You hear this constantly over and over. We don't know what the short term, we don't know what the long term effects are. All right, so basically we really need to be studying a little bit more before we jump on the bandwagon, because you're seeing it on the internet, you're seeing it advertised, you're seeing it everywhere. Take this, but there's a lot of people making a lot of money. It's expensive. It's very expensive, all right? Probably more than your routine meds that you take that are prescribed by the doctors, and in reality, it's not covered by Medicare. So, and the last slide is, what we're really doing is looking to provide that quality of care and quality of life that we want happy patients. All of us should, you know, be in a good place when we're dying. Death is inevitable, and my goal, at least, is to see that you are in the most comfortable place with the best quality of life and best quality of care. It's not always easy to do, but we work hard, and that's where geriatrics and hospice docs are really important in trying to provide that. So with that, I'll stop and thank you, and for any questions, we'll open it up to questions.